morning, everyone. I'm going to be talking to you today about diabetic ketoacidosis. I'll show you this at the end because you can't see it that great right now. But a little backstory, I got my grand rounds paper on a 16-year-old girl who had come in for the second time with diabetic ketoacidosis. She did have type 1 diabetes, and she was non-compliant with checking her blood sugars and also giving herself insulin. She even told me that for 2 weeks she just decided that she wasn't going to take or check her blood sugars anymore, which obviously meant she wasn't taking any insulin. So she's non-compliant with her diabetes. Doctors came around, said if you do this again, we're not going to let you drive. And being a 16-year-old girl obviously is a big deal to drive. But that is a risk, she could be held responsible if she went into, whatever while she was driving and they found that her blood sugars were either too high or too low. The accident could be her fault. So, they decided to discharge her home with plans of meeting up with her endocrinologist in a couple weeks to eventually get an insulin pump, which they thought maybe would benefit her a little bit more. I'm not really going to be talking about the insulin pump thing today, but we'll talk about the reason she was in the hospital. So, the etiology and pathophysiology of diabetic ketoacidosis is caused by a profound deficiency of insulin and characterized by hyperglycemia, ketosis, and dehydration. Occurs mainly in patients with type 1 diabetes mellitus, but also they've seen it in type 2. It's just not as common. Risk factors for getting diabetic ketoacidosis is illness because it increases your blood sugar levels when you're sick. Infection also increases your glucose. Just stress in general sometimes increases blood sugars, so they want people to be monitoring that a little bit more. If they're in the hospital, that's kind of stressful. If they had surgeries, that's another stress on the body. Those are reasons why people's blood sugars increase. Also, anesthesia increases your blood sugar. Inadequate insulin dosages. Obviously, if you're not getting enough insulin, your blood sugars are going to trend higher. Undiagnosed type 1 diabetes. If you don't know you have diabetes, you're obviously not giving yourself insulin. Poor self-management. In my lady's case, she was not taking her insulin and not checking her blood sugars. So that would show that she has poor self-management and also neglectful of her diabetes. Okay, clinical manifestations that you should be looking for are poor skin turgor, dry mucous membranes, tachycardia, orthostatic hypotension, which are all kind of due to the dehydration that the patient is experiencing, lethargy, weakness, Kussmaul respirations, which are the periods of apnea when that's what you'll see in patients. They'll be breathing and then they'll stop breathing for about a minute and then they'll start breathing again. Sweet smelling breath, which is the buildup of acetone in the body, which makes the breath smell sweet. Urinary frequency, and nausea and vomiting. Complications are severe deprivation of sodium, potassium, chloride, magnesium, and phosphate. This is caused by dehydration. Let's just go over the normal lab values for fun. It's just a little quiz. Sodium, 135 to 145. Potassium, 3.5 to 5. Chloride, 96 to 106. Magnesium, 1.7 to 2.2. Phosphate, 2.5 to 4.5. And I don't remember if I said those are caused by dehydration, but that's the reason why all those electrolytes are low. Hypovolemia followed by shock. So the hypovolemia kind of causes the shock. Renal failure causes the retention of ketones and glucose. So the renal failure is caused by the ketones and glucose being built up into the kidneys. People aren't, they're peeing a lot, and a lot of ketones and glucose in the urine. They can end up in a coma as a result to dehydration, electrolyte imbalances, and acidosis, and they could eventually die if this goes untreated. The diagnostic studies that you will be looking for are the blood glucose level greater than or equal to 250 milligrams per deciliter. I don't know what I was going to say. Arterial blood pH less than 7.3, which would make them acidotic. Serum bicarb levels less than 16 milliequivalents per liter. And moderate to large ketones in the urine or serum blood. These are all things that you'll be seeing. Those aren't good things. Those will be seen when they first come into the ER or hospital or wherever you're seeing them first. So we'd like to see those go down eventually. My nursing diagnosis was risk for fluid volume deficit related to excessive gastric losses due to nausea and vomiting. So because they're, nauseous and vomiting often, that adds on to the dehydration, which leads on to the hypovolemia, which could lead on to the shock. So they all kind of build in together, unfortunately, so that can kind of get away from you quickly. Collaborative care. So I have several things that you should be monitoring for. You should be monitoring the vital signs, the level of consciousness, cardiac monitoring, and that has everything to do with your monitoring for shock. You're going to be wanting to monitor those. If you're starting to see your patient go into shock, you're going to want to have them be monitored every 15 minutes or so. With the vital signs, you're going to be looking for increased pulse and respirations. The MAP is going to decrease by 10 millimeters of mercury. The MAP is the mean arterial pressure. If you guys haven't gotten to that yet, I'm not really sure. I don't remember. So, in a normal MAP we like to see 60 to 100. So you'll start to see the MAP trend down. You'll start to see the heart rate kind of increase, the respirations kind of increase, and those are really early signs of shock that you should be monitoring for because at this point you can still correct the shock, and that's what you're going to want to do. So again, the vital signs, level of consciousness is another good indicator of shock. If they're starting to become restless or irritated, that's another good sign that something might be going on, and you should probably be monitoring them a little bit more closely. Cardiac monitoring, that's more for if the potassium's low. O2 saturations, that's always a good one to look for. That could also cause restlessness and irritation. And the urine output, that's going to show kidney function obviously, but you're going to want them to be peeing at least 30 milliliters an hour to maintain good kidney function. You're also going to want to assess breath sounds because you're going to be looking for that fluid overload. You're going to be giving them aggressive IV fluids, and you want to make sure that they're not going into fluid overload at all. You want to monitor their serum glucose levels, obviously, and their serum potassium because that's another serious. You don't want to throw them into a dysrhythmia. You want to administer potassium to correct hypokalemia. Administer sodium bicarbonate if severe acidosis, which that means the pH is less than 7. And administer dextrose. Administer dextrose in IV fluids for blood glucose less than 250 milligrams per deciliter. And that's because you don't want their blood sugars to drop too rapidly, so they want it to kind of go down slowly, so they're going to give them a little dextrose to kind of help the blood sugars go down slowly, because if you had a rapid drop in blood sugars, that would just not, that's not great. So I found another thing I have another few extra little supplemental things that I thought was helpful that might help you guys kind of understand this a little bit more. So I thought this was interesting, the client education guidelines during illness. Take insulin or oral anti-diabetic medications as prescribed. Determine the blood glucose level and test the urine for ketones every 3 to 4 hours. If the usual meal plan cannot be followed, substitute soft foods 6 to 8 times a day. If vomiting and diarrhea or fever occur, consume liquids every 30 to 60 minutes to prevent dehydration and to provide calories. Notify the healthcare provider if vomiting and diarrhea or fever persists. If the blood glucose levels are higher than 250 to 300, when ketonuria is present for more than 24 hours, when unable to take food or fluids for a period of 4 hours, or when illness persists for more than 2 days. So those are things that extra things we should be doing for people who have diabetes that are maybe in the hospital with not anything to do with diabetes, but if they're sick or had a surgery, you need to be monitoring their glucose a little bit more closely. I also have a video. Just hold on. I guess I need this. And I'm sorry, I do not know how to flip this thing around, so I'm just gonna hold it up, I guess. I don't know. Okay.
As a family doctor, one of my jobs is to try and keep people well. That means preventing disease before it happens. So one of the things we try and do is try and ensure that people get screened for cancer so we can catch it early and prevent death from cancer. In our own practice in downtown Toronto, we worked hard to...
That was not the right video. Just give me 1 second. I'm sorry, this is so clunky. I'm doing what we can here, with this quarantine. I don't know why it went to a different video. Okay.
So you have type 1 diabetes. It's something you're going to manage, mostly with insulin, a hormone your body doesn't produce when you have type 1 diabetes. By now, you probably know how and when to give yourself insulin. And if you have an insulin pump, you probably know how to maintain it. But do you know how to tell if something's not working? That's what we'll be looking at. You eat carbohydrates to fuel yourself with energy. Your body breaks down the carbs into sugar, which then goes into your blood. Think about it like filling up the gas tank in a car. When you eat, your body stores the carbs to use as energy when you need it later, like filling up the gas tank. Insulin is what opens the tank to let the gas in. As someone with type 1 diabetes, you don't produce insulin naturally, so the sugar doesn't get to where it's supposed to be, which is why you take insulin. If you're not getting the insulin you need, the sugar you eat stays in your blood instead of being stored in the tank. When this happens, your body won't have the fuel it needs when it needs it, and your body will seek out alternative sources to break down into fuel. One of the first sources it looks for is fat. Except when your body breaks down fat, it leaves ketones in your bloodstream that make your blood acidic. Together with high blood sugar, acidic blood from the ketones can make you sick and put your body in a state of diabetic ketoacidosis, or DKA. And DKA is really, really serious. It can even be fatal. The most common reasons for DKA happening are developing type 1 diabetes, missing taking your insulin, getting an infection, and malfunctioning equipment. Your body will give you plenty of pre-DKA warning signs before you're in serious danger. You may pee more than usual, which is your body getting rid of the sugar that isn't making its way into your cells. You may feel thirstier than usual, which is your body diluting the unused sugar in your bloodstream with water. You may find yourself breathing faster, which is a way your body tries to compensate for acidic blood. And you may feel tired and weak. If you notice any of these warning signs, check your blood sugar and also check your blood or urine for ketones. If you are worried or you're not sure what to do, call your diabetes care team or go to the hospital. Remember these easy steps to prevent DKA. Test your blood sugar regularly. Always take your insulin, even when you're sick. If you are sick, stay hydrated, and you may need to take more insulin than normal. If you wear a pump, check regularly to make sure it is connected and working. And if you notice any of the DKA symptoms, check your blood or urine for ketones. Want to know more about DKA? Have other questions about managing your diabetes? Ask your diabetes care team and stay tuned for more videos to help you stay healthy and continue to live the life you want.
Well, they said it better than me, so I just thought that was a little helpful video. I can link that wherever if you guys want to watch it again, not through my crappy laptop screen. Oh shoot, hold on. Okay, I'm just going to lay my poster board down and kind of do a little close-up view so you guys can read these maybe a little bit better. It's all the information I already went over. I'm just going to show you a little bit closer up. This is just a little picture of how it kind of works. It's in the book, I believe. And then my references for Dawn. Well, thanks for watching.